Welcome to the presentation for Module 8 for Management of Patient Oxygenation Needs. This portion is Part 1, and for this portion we will discuss non-infection upper respiratory tract disorders. We will also review the anatomy and physiology of the upper respiratory tract and the assessment of the upper respiratory tract. The respiratory tract is responsible for providing oxygen for metabolism to the tissues and to remove carbon dioxide, which is the waste product of metabolism, from the body. Other function of the respiratory system consists of smell, speech, helps to maintain an acid-base balance in the body, helps to maintain body water levels, and can also assist in the maintenance of heat balance. The organs of the upper respiratory system include the nose, which humidifies, warms, and filters the air, your sinuses, which are air-filled cavities within the hollow bones that surround the nasal passages and provide, helps to resonate speech. Your pharynx is also a passageway for the respiratory and digestive tract located behind the oral and nasal cavities. It's divided, the pharynx is divided into the nasopharynx, the oropharynx, and the laryngopharynx. The larynx is located just below the pharynx at the root of the tongue, and it's also known as the voice box. We have two pair of vocal cords, and that is how we make sounds. The epiglottis back by the larynx is a flap at the top of the larynx that prevents food from entering into the tracheobronchial tree. It closes over the glottis during swallowing. The organs of the lower respiratory system consist of the trachea, the bronchi, the bronchioles, the alveolar ducts and the alveoli, and then the lungs themselves. We will talk about the organs of the lower respiratory tract in the parts of the presentation that cover the lower respiratory tract disorders. As with any of the other body systems that we've discussed, there are some particular changes that do occur in the respiratory system related to aging. And there's multiple things that you can review. There is a chart in your book, in your IGGI book, that talks about how the alveolar surface area decreases, elastic recoil decreases in the lungs, the ability to cough effectively decreases, elasticity decreases in the lungs, and then also there's some things that can affect the pharynx and larynx. The vocal cords become more slack. Laryngeal muscles lose their elasticity, so there's a lot of loss of elasticity in these muscles and in organs as we get older. The patient's general respiratory muscle strength is not as strong when people get older, and people are more susceptible to infection due to the fact that the cilia within the bronchioles, the effectiveness of it decreases. Osteoporosis is possible as well, leading to chest wall abnormalities, so it could cause like some kyphosis, some hunching over due to osteoporosis. So lots of different things about aging that can affect your respiratory system and put a patient more at risk for having disorders. As we said, the respiratory system is responsible for the oxygenation of the tissues. We need oxygen for our cells to live and perform their specific jobs. Oxygen intake with a proper gas exchange and perfusion to the tissues is the role of the respiratory system. Priority concepts that we will discuss as we discuss the respiratory system is gas exchange and perfusion. So the actual exchange of the oxygen and the CO2, and then the perfusion of the oxygen to the tissues. Make sure that you review the proper assessment of the respiratory system. Review how to assess someone's nasal cavity and their sinuses. Typically with their nose, you're looking for patency, symmetry, any deformities. And to assess the interior of the nose, make sure you But ask the patient to tilt the head back and use a pen light to take a look in there and look at their turbinates, look at their, make sure that there's patent, looking for drainage, things like that, color, swelling, drainage, bleeding. The mucous membranes of the nose normally appear redder than the oral mucosa. If it's pale, engorged, or bluish, the patients typically have an allergic rhinitis. You can also block one nary at a time to check how well air moves through the unblocked side. Review assessment of the pharynx and the trachea and the larynx. This is where you're going to start with the mouth, taking a look at the mucous membranes. To examine the pharynx, you would use a tongue depressor to press down the tongue, because a lot of times the tongue gets in the way and you can't see the tonsils back there. Have the patient say ah. As they say ah, this causes a rise and fall of the soft palate, allowing you to a better view of their tonsils. You're looking for edema, drainage, ulcerations back there, redness, of course, in the back of the throat. I know you know, and you've gone over this many times in your clinical and your 121 about the assessment of the lungs and the thorax. Make sure you review that as far as breath sounds. What are abnormal breath sounds? What are normal breath sounds? Make sure that you review what each abnormal breath sound indicates. You're looking so many different things when you're looking at someone's lungs and thorax. You're looking for symmetry, making sure that their respirations are even and easy. Looking for your rate, your depth of inspiration, type of breathing, so many different things that you're looking at. Palpation can identify fremitus, crepitus, which means that there's air under the subcutaneous tissue. Percussion, to assess for pulmonary resonance, the boundaries of the organs, things like that. Make sure you just kind of review that, and hopefully you're doing some of those in practice in your clinicals. Auscultations, make sure you review how to auscultate, the formula for doing that, doing it bilateral sides, and doing it usually from the apex down to the bottom. And remember, the person's just general appearance, skin and mucous membranes can be an indicator of how well they're oxygenating. If they are pale, grayish, general appearance of if they're working hard to breathe, if they look miserable, if they look ill. A lot of times patients who have pulmonary issues that cause them to have a lot of work of breathing, they will be thin and frail looking, and that's because a lot of their energy has to be put into their work of breathing, and that can take up a lot of their metabolism and make them appear frail and thin. You do have a good table in your IGGI book, the characteristics of adventitious breath sounds. Make sure you review those, not only just for this class, but also for your use in clinical. This is just a review of some of those breath sounds and assessments of the pulmonary system that you should be doing. Assessment of the pharynx, trachea, and larynx is basically monitoring for that patency. We typically assess these areas of your respiratory tract when someone is complaining of sinus symptoms, sinusitis symptoms, rhinitis symptoms. If they're having trouble breathing, we're checking that area to make sure that those are patent areas. Maybe if somebody's complaining of a sore throat, those are times when we would perform an assessment. Or if we have reason to believe that someone's airway is swollen, or they're having trouble having a patent airway, we would look at those areas. One thing I just want to bring up just briefly is the upper respiratory tract. Look at the jobs of some of these organs. The nose is meant to filter and warm the air that we breathe in. That's part of its role. And that kind of cleans the air before we get it into our nasal passages and into our lungs. That's an important job of that. The characteristics of these normal breath sounds, typically bronchial breath sounds sound kind of tubular. They're high pitched and they're usually heard over the trachea and the larynx, which is up higher. The bronchiovesicular breath sounds are usually over major bronchi, where fewer alveoli are located, so they're kind of in the midsection, and they're kind of a moderately pitched breath sound. Vesicular breath sounds are typically heard over the peripheral lung fields where air flows through the smaller bronchioles and the alveoli. They are very low pitched, which makes sense because they're down lower in the smaller areas. Bronchial breath sounds heard at the lung edges are abnormal and occur when the bronchial sounds are transmitted to an area of increased density, such as with atelectasis, a tumor, or pneumonia. So that's why it's good to kind of try to differentiate between the different types of lung sounds. So if you hear the bronchial breath sounds down at the lung edges or in the periphery, that could mean that someone has increased density, which means, because you should hear air flowing through all these areas. When they have increased density, this means that there's fluid in there or infection or possibly a tumor to make it sound more dense rather than air flowing through there. So the first abnormality we're going to talk about is cancer of the nose and sinuses. So again, just to review, we're talking about the upper respiratory tract when we're talking about these two areas, the nose and sinuses. They're important for gas exchange and perfusion by providing the entrance site for air. Problems of the upper airways, especially when you're talking the larynx and trachea, can interfere with oxygen delivery. Patients with upper respiratory problems are found in the community in all healthcare settings. The nursing priority with disorders of the upper respiratory tract are to promote gas exchange by ensuring a patent airway. That's key here. Cancer of the head and neck usually occur within the larynx, the trachea, the throat, the oral cavity, or the tongue, and they usually arise from skin or mucosa as squamous cell carcinomas. Cancer of the nose and sinuses are very rare. They may be benign or malignant. It's more common among people with chronic exposure to some kind of a carcinogen. It can be things like things in the environment like dust, chemicals, chromium dust, mustard gas, things like that. Cigarette smoking, of course, will increase the risk. Usually this is a slow onset cancer. People might just think they have like a chronic sinusitis. This would be when a provider would note that maybe a person with a chronic sinusitis might appear to have a nasal obstruction on assessment. So that's why it's always good to do a good thorough assessment in the nasal cavities. Bloody discharge and pain that persist and lymph node enlargement can be indicators that it's more than just a chronic sinusitis. Surgical removal of the tumors are typically pretty effective. Sometimes they'll do radiation therapy. Problems after surgery, especially it could be a body image thing if the surgery causes any kind of a facial deformity, which could happen. And then also you got to always watch that airway. And then if there's a cancer of the nose or sinuses, you could have effects on the sense of smell. This is just a picture to review exactly what we're talking about when we're talking about the sinuses and the nares and how they kind of all the air comes up through the nare here and kind of goes through. So this job of all these terminates in here is to kind of clean and filter the air as it comes back here and hits in the back of the pharynx and the larynx back here. So as you can imagine, everything that we're exposed to on a daily basis goes through this way, and it can cause, if it's something that's toxic to the body, it could cause a cancer. People with head and neck cancers typically will begin to complain of a chronic hoarseness. They might palpate lumps in their head or neck. Mouth sores that won't heal are indicative of maybe a head or neck cancer. Feeling like they have something stuck in their throat, a chronic weight loss due to a difficulty swallowing. This is the physical assessment. Other assessment would be asking a patient about their tobacco or alcohol use, because that could put them at risk. Ask them where they work. Ask them what kind of environment they're exposed to on a daily basis. And it's important just to understand that head or neck cancer is always going to be putting a patient at risk for an airway obstruction. Radiation therapy, again, and chemotherapy are treatments for all cancers. It could, the radiation therapy could shrink a tumor, and then it could be removed surgically. The important thing to understand here, head and neck cancers, of course, we'll do an assessment, find a patient who appears to be at risk for having a head and neck cancer. There's x-rays, CTs, MRIs are also going to be tools that we're going to use to diagnose this. And then a biopsy of the area would also be something that we would utilize to make the diagnosis and then treat with radiation or chemotherapy if we identify that it is a cancer. A cordectomy or laryngectomy is a removal of the cords and a removal of the larynx. If that has to occur, the patient may require a artificial airway known as a tracheotomy. That's a creation of an artificial airway. A creation of an artificial airway, like a tracheotomy, is always going to put the patient at risk for an airway obstruction, and at risk for increased infection. And remember, they're at risk for increased infection. A lot of it's because now they're not breathing the air in through their nose like we were meant to. And remember, the nose filters and warms the air that we put into our lungs. If they're breathing through a hole in their neck, they lose that ability to filter the air and warm the air and humidify it. So it's dry air, it's more dirty air, so it puts the patient at risk. And then our job as a nurse is to monitor a patient with an artificial airway to make sure that it maintains patency. This is just a picture. This does come from your book. It's the possibility of a laryngectomy, where they have to remove the larynx here and create a stoma on the outside of the body as another way for way for the air to flow down to the lungs. Besides losing the ability to move air through your normal air passage, now you have an artificial airway. It also changes your ability to communicate, especially if the cords are removed. And usually that has to occur if someone has to have part of their larynx removed. And so we have to create alternate ways for them to communicate, because you have to have your vocal cords in order to make sound and speak. So this is just an example of a way that we can do some artificial ways that it's almost like artificial cords is what this creates, like a prosthesis, in order to have the ability to communicate again. The following slides are as a case study and a few questions going over the information that was just provided regarding non-infectious disorders of the upper respiratory tract. I encourage you to try to answer the questions, and then the answers are provided in the PowerPoint in the comment section. I encourage you to try to answer the questions and then check yourself to assess your learning.